So, what are the aims of cancer rehab? The aims primarily are restorative care, supportive care, palliative treatment, and preventive rehabilitation. Restorative care is retained to return to pre-morbid function with a minimum of functional impairment. Supportive care is reduce the functional difficulties and compensate for permanent deficit. And palliative treatment is works to eliminate or reduce complication, particularly pain. And preventive rehabilitation is preoperative education regarding maintenance of strength and range of motion, like is for example upper extremity following brain surgery. So, what are the common problem? Common problem in cancer patient is primarily pain, lymphedema, fatigue, immobility or generalized deconditioning, depression, and some system-specific problems like myopathy, neuropathy, bone restriction, and sometimes chemotherapy-induced side effects like nausea, vomiting, fatigue, hair loss, susceptibility to infection, decrease in blood cell count, and mouth sores ulcers, and sometimes radiotherapy induced side effects like loss of elasticity, vascularity, tissue thickening, edema, or contracture like that. And primary problem of cancer pain is tumor-related pain, like compression or infiltration due to tumor. Sometimes it's treatment-related, like post-surgical pain, phantom limb pain, stomach pain, etc. Sometimes it's due to debility, they like infection, pressure sore, constipation, bladder spasm. Sometimes it may be due to comorbidity, like even angina or arthritis. Sometimes it may be due to psychological pain or spiritual problem. So there are a lot of things which should be considered in patient with cancer pain. So now the question is that do all cancer patients suffer pain? Answer is it's very significant percentage, like 40 to 50% of cancer patients suffers from moderate to severe pain, and 25 to 30% patients suffers from very severe pain. 80% of terminal stage cancer experience moderate to severe pain. But there are a lot of options regarding cancer pain management. The different types of medications available, but transdermal patches, particularly diclofenac patches and ketoprofen patches are useful. We are frequently using buprenorphine patches and painternin patches in management of in cancer pain. Particularly, radiation therapy is very much important in management of cancer pain. Radiation per se can relieve pain by killing cells to reduce tumor size. It can promote remineralization of bone and can predominantly used for primary tumor-associated osteoblastic metastasis. It usually delivered as external beam treatment or systemic radioisotopes. Sometimes chemotherapy kills cells and reduce tumor size and reduce tumor compression and nerves, and it is not suitable in tumor which are not chemosensitive, but it can reduce pain itself by reducing the tumor size. What are the other complementary and alternative medicine therapy approach like CAM therapy, where acupuncture, acumatherapy, hypnotherapy, massage all can increase the well-being and thus influence pain. It can be employed in additional to conventional treatment in palliative and supportive care, cancer care, and a large proportion of cancer pain a patient can be used by CAM therapy. But there are different types of interventional procedure, like fluoroscopic or USG guided procedure. Nowadays, we are using in management of cancer pain by using different types of agents, starting from local anesthetics to steroid to neurolytic agent, and RFA is also quite useful in management of cancer pain. Like in case of different types of palliation of cancer pain, particularly which involves the rib invasion or and ultimately leading to chest and upper abdominal pain, wall pain, can be managed by intercostal nerve RFA or neurolysis. Here we have to think about the complication of pneumothorax and intercostal neuritis. That's why guided approach is quite useful. You can see in the picture that this is the USG picture, and here the ribs you can see, and this is our target area for giving the injection This can you see the B area? And this is the target area to putting the injection or do the RFA in this intercostal nerve. And nowadays, celiac plexus block are quite useful in case of pancreatic, gastric, and biliary malignancy. Particularly, it is also useful in metastatic liver cancer and retroperitoneal lymph node metastasis. And you can see in this video that the target area is D12 areas. Sorry, the sound is on. Excuse me for that. D12 area. So we have to approach and from bilateral side, we need to put the pin needle just in front of the D12 vertebra, and you can see the dye infiltration there. And in that way, we can reduce the pain. Celiac plexus block, I'm sure that a lot of my colleagues and juniors are nowadays doing. And we have done RFA also of celiac plexus now, plexus. And this is a patient where the celiac plexus block is going on for a patient of pancreatic cancer. This patient has been referred from our department of gastroenterology and responded well initially. But from my experience, I can tell that duration of the main limitation is that the pain relief is not long lasting. Most often, the patient need to go for a repeat block or RFA after few months time. But anyway, most of this cancer, like pancreatic, biliary, and gastric cancer, actually the overall prognosis is very poor. Survival rate is generally 1 year time or some more or less like that. So in that case, this type of celiac plexus block or neurolysis, I think is quite helpful and effective. For another thing is the splanchnic nerve block that in similar type of cancer, we can go for a splanchnic nerve block also. Here we need the level is more or less same D12, but we should not go more than the junction of posterior two-third and anterior one-third of the vertebra. But here also there is a chance to develop pneumothorax and retroperitoneal fibrosis or nerve injury. And then the next is that for the superior hypogastric plexus RFA or neurolysis for pelvic malignancy and pelvic metastasis. We have done a project on this topic. One of our PGs has done on neurolysis. We are doing RFA regularly, and I can tell you that actually the prognosis of this superior hypogastric plexus block or RFA in pelvic visceral malignant pain is very good, and it is quite long lasting and very much effective. You can see that RFA, this is conventional RFA is going on, and this conventional RFA is quite sufficient enough to reduce the pain of manage this pain of pelvic malignancy in this type of patient. And next is your ganglion impulse block. This is also very good in management of pelvic region CA or pelvic region neuropathic pain or perianal metastasis. And I'm sure that a lot of our juniors are doing ganglion impulse block in their institute. It's quite easy, and I will suggest him that if you have the facilities of RFA, you can jolly well go for RFA of ganglion impulse block in pelvic malignancies and pelvic neuropathic pain. Here only that we need to check about is there any chances for rectal perforation, which is very, very rare and unlikely. Infection and fistula, development of fistula are the known complication, but these are also very rare. And we have done both combined ganglion impaired and superior hypogastric block also in those type of malignancy, and this is quite good and effective. Then another very important modalities in current day practice is intrathecal drug delivery system. It is actually an invasive procedure, but as per literature, it is quite effective. You can see that there is a literature published that it is showed that that IDDS improved clinical success in pain control reduce pain, significantly relieve common drug toxicities, and improve survival in patients with refractory cancer pain. So the intrathecal drug delivery system, the two beauties is that actually it relieves and it reduces drug toxicity. That is very important. And overall, the reduction of pain control is very good. Though the delivery system is quite costly, but there is other literature also. This is published in Pain Medicine. We showed that 59% patient successful reduction of dose titration, 42% in all patients considered with long-term success rate. And this is actually the drug was intrathecal clonidine was used in this patient. And there are some controversies and the literature regarding the patient triggered and nursing control demand dosing of patient control analgesia. And then here patient triggered is quite effective, but when there is a nursing control, the toxicity doses are bit lesser. We don't have any direct exposure about the introduction of spinal cord stimulator and intrathecal drug delivery system in pain management, but we have some exposure about the intrathecal implantation of baclofen pump. And I can tell you, as per the steps, it's more or less the similar type of steps into the system implantation. Another is very common and relatively a bit exceptional thing, that is the rehabilitation of fatigue. And here there is a lot of animation of slide. Can you see my slides now? Hello?
Hello, sir.
Hello?
Slides are visible.
Yeah, the rehabilitation of fatigue actually is the feeling of extraordinary exertion associated with high level of distress, disproportionate to the patient activity as not relieved by sleep or rest. Up to 70% of cancer patient suffers from fatigue due to inactivity of muscle catabolism and sometimes perpetuate fatigue. So cancer-related fatigue leads an impact on physical functioning and ADL, which can ultimately cause psychological distress and economic burden and influence caregiver and the family members also. As per the International Classification of Disease, 10th edition, the criteria of cancer-related fatigue is diminished energy with increasing need of rest, limb heaviness, diminished ability to concentrate, sleep disorder, inertia, and emotional lability, and perceived problems of short-term memory, etc. And there are a lot of reversible sources of cancer fatigue pain. One of the most important thing is anemia, which we should look for, and insomnia. Sometimes endocrine problem like hypothyroidism, hypogonadism, sometimes depression and deconditioning, steroid myopathy, etc., which and even the pain or adrenal insufficiency is the cause of fatigue pain. But when there is adrenal insufficiency, most of the time there is metastasis in the adrenal gland. So management of fatigue, actually when there is adrenal insufficiency, so in that case we need to go for steroid management and corticosteroid, so, modafinil we can use, L-carnitine, methylphenidate we can use. And occupational therapy, particularly the use of energy conservation technique, diversional activities, rest and sleep pattern, stress management is important. Regarding physio, aerobic exercise, endurance training is important. And for restoration of energy balance, we need to correct anemia, nutritional and vitamin supplementation, and we need to correct endocrinal dysfunction, including hypothyroidism, hypogonadism, etc. And definitely we need to address the depression also. Another issue in cancer, particularly for the exam point of view, is the lymphedema, particularly post-mastectomy lymphedema. Yeah, the causes is resection of lymph node, radiotherapy, and chemotherapy. When the patient presents with heaviness and tightness and numbness of the limb, even stiffness of the joint, and it may develop even months or years later the surgery or the chemotherapy. And complication of lymphedema includes deformed limb, Stewart-Travis syndrome, elephantiasis, and orange appearance. Sometimes it is in exam. This question actually quite frequently asks why orange. What is orange? It is dimple texture like a orange peel caused by lymphatic edema, an infiltration of skin tethered by sweat darks which cannot swell. That's why the appearance is orange-like. That's why it's called orange appearance. You know there are three stages of lymphedema. Stage 1 is characterized by pitting edema, which is reversible with elevation of arm. Stage 2 is no longer spontaneously reversible. Here, the development of protein-rich edema and proliferation of fibrotic tissue. And stage 3 is the known case of elephantiasis and massive swelling of the extremity due to protein-rich swelling. Management of lymphedema is primarily patient education and counseling. Role of medication is very less, only antidepressant may be used. Most important is physio. CDT, CDT is very, very important, and paradism under pressure with intermittent pneumatic compression is very, very helpful for this type of patient. And CDT, there are a lot of component of CDT like MLD, therapeutic exercise, multi-layered short stretch compression bandaging, skin care, education, elastic compression garments. And I am telling all the pages, this is very frequently asked questions about CDT. And there are different phases of CDT. Phase 1 is primarily used to reduce the lymphedema volume. Approximately 40 minutes of MLD is needed with compression bandage, and compressive bandage left for 21 to 24 hours per day. And phase 2 is primarily remedial exercises and MLD as needed. And MLD is another issue which is frequently asked in the exam. It is the lymphatic massage only, and it is done from the proximal to distal areas. And there is a small video of this one, the CDT one, and the physio is doing this thing. I'm sorry, it's not running. It is proximal to distal clearance of the lymphatic, and that's why and very light pressure is given. 30 to 45 mercury of mercury pressure is given in CDT MLD. And then another issue is Faraday under pressure. There are a lot of electrode primarily placed under the elastic compression bandage, and surge Faraday current is used with a surge duration of 3 seconds with surge interval 9 seconds, and intensity is enough to produce visible contraction of muscle with that can clench up toes or fingers. Treatment time is usually 15 to 30 minutes. Skin care in lymphedema is very much important. There are a lot of do's and don'ts. We need to remove the debris and bacteria with moisturization of skin. Another important issue is that intermittent pneumatic compression pump. Contraindication is acute infection, severe arterial diseases, acute superficial or deep brain hepatitis, recurrent cancer in affected area, and uncompensated CCF. These are the contraindication. And there are some indication for surgery in lymphedema. When there is an excisional operation like debulking operation, tissue transfer, and microsurgical lymphatic reconstruction may be needed when it is not managed by conservatively. And sometimes the patient actually asks for the surgery for the cosmesis purposes. So this is very important, is post-mastectomy lymphedema. Another, there are some specific condition which should be primarily give some importance is management, like metastatic bone involvement is very common. 75% metastatic bone disease is due to breast, lung, or prostatic cancer. 25% is due to renal cell CA, thyroid, lymphoma, and myeloma, etc. Male 60% secondary to prostatic cancer, female 50 to 60% secondary to breast cancer. Mostly metastasis is multiple, it's rarely solitary. Axial skeleton is involved in case of lot of cases. In 70% is primarily involvement in the thoracic spine, and 95% is actually extradural in origin, and 5% is dural in origin. axial skeleton. When there is involvement, we need to think about the stability of the column. It is only so when it is only one column is involved except middle, it is stable. Otherwise, more than two is unstable. We know that when there is an unstable column, definitely we need to give some orthotic support for this patient, or patient may require a surgery. For the extremity metastasis, in upper limb, mostly more than 90% are the humerus, and in lower limb, mostly in the hip and femur areas. Hip primary source is prostate, breast, lung, and lymphoma. In case of femur, breast, renal, multiple myeloma, and prostate. Another thing is that is this metastasis osteolytic or osteoblastic? For osteolytic, we need to be especially give more importance because these are more prone for fracture. Primary malignancy are myeloma, lung, and lymphoma. For the osteosclerotic, most important is the steepness and actually decreased range of motion. Here, prostatic cancer is very much important. The main clinical presentation is pain, pain, and pain. Sometimes it's biological pain, sometimes it's mechanical pain, or sometimes there's a spinal pain, which should be addressed. And sometimes patient may present with pathological fracture. Mostly the proximal femur is the most common area where the mobility is a great issue. So we need to address these areas. Sometimes a neurological probe disorder for this bone metastasis starting from radicular pain to autonomic dysfunction, weakness, sensory alteration, etc. Sometimes some cranial nerve involvement is also there. So we need to check about the essential assessment of all this clinical examination, including checking the marker of specific malignancies. We know about different marker of different malignancy, but imaging is very, very important. Bone scan for early detection is good, but we need to know that false positive bone scan come from the prior trauma or degenerative diseases. False negative bone scan may be due to bone destruction without ongoing repair or bone metabolism. Here, the PET CT scan is always good. It is highly specific, highly sensitive. It is due to increased uptake of 18F sodium fluoride. And there are a lot of treatment options starting from pharmacological to orthotic support to radiation to surgical stabilization. It depends upon the location of lip lesion, degree of associated pain, presence of risk of fracture, radiation responsiveness, etc. And there is a clear-cut algorithm available regarding the bone metastasis, where we need how need to follow it up, and where is the role of radiation, where is the role of surgery, and hypercalcemia is very, very important issue in bone metastasis. Or never forget to look for the hypercalcemia. And there are three specific important symptoms we need to look for, as you know: psychiatric moan, abdominal gone, renal stone. The patient generally suffers from actually depression, different types of psychological issues, diffuse vague abdominal pain, and renal stone. When there is an polyuria, polydipsia can happen. When these type of symptoms are there, always check for calcium level, because this is the important thing which can land up with catastrophe if you miss it, because severe hypercalcemia land up with cardiac arrest, even due to short QT interval. When there is a level initially mild to moderate hypercalcemia, you can treat with only hydration and observe it. But when there is a significant hypercalcemia, then you have to think about the significant hydration with bisphosphonate, sometimes tamidronate, or zoledronic acid infusion, administration of calcitonin plus saline infusion for 12 to 48 hours, and additional more aggressive measures may be necessary, like hemodialysis should be considered if the range is 18 to 20 milligram per deciliter and with neurologic symptoms, because this hypercalcemia again may be complicated with renal failure. So when there is a significant hypercalcemia, always do an ECG and look for is there any short QT interval J-bone wave, and other features of hypercalcemia. There is significant role of bone resorption inhibitor like bisphosphonate for primary medication, and it should be initiated empirically. Now denosumab is freely available and it is quietly effective in management. Now another molecule which I have an exposure for you to use it in UK, that is strontium 899. It is quite good to manage refractory severe pain in case of bone metastasis, and see the strontium 89 in highly effective in prostatic CA, but I think it is not available in India. I have searched for, but I have looked, I have got the strontium here. I don't know it available in other center or not. Radiation therapy, there are important issues that it is multifractionated radiation or single dose radiation which are effective. So regarding MFR, you can see that 10 fraction is required, but for single dose of 18 gauge is sufficient. And if you see the comparative study regarding the pain relief, neuropathic pain relief, recurrence rate, additional radiation, all this stuff, you can see that single dose irradiation is quite good. Only that sometimes additional radiation may be required, but otherwise, even single dose radiation is very good in management of radiation pain. Sometimes surgery may be needed for spinal tumor resection, long bone problem, but it is not recommended of 48 hours since complete paralysis has happened or when the prognosis is predicted within 6 months of time. There are some indication of surgery. I am not going into the detail, but one thing I can tell you regarding our rehab point of view, that vertebral fracture with severe pain and compression fracture vertebroplasty is nowadays is very important in our, and it is the role is well established in the literature, and here in our center we are doing it regularly, and I actually suggest every center to start percutaneous vertebroplasty and kyphoplasty. It is not that difficult. It is jump set should be introduced. The size depends upon the lumbar or the dorsal segment. It may be 11 or 13 according to that, and you need to put the needle there in the, you don't should not cross the middle, and then you need to prepare the cement and introduce it. It is very good to reduce the pain, particularly due to vertebral compression fracture, and it can even eradicate the use of other teriparatide and other medicine, and even the orthotic support of the
Hello, sir.
vertebroplasty.
Sir, actually, we are
So
running
this
short
is
of time.
very
Please conclude.
important issue. Sorry.
Sir, we are having short of time, sir. Please conclude soon.
And other things about the issues. So I don't want to take the time over those issues. Just to conclude that cancer pain management is very important issue, but a lot of other issues are also very important from the RIA point of view. But for the advanced cancer, we need to definitely think about different policies, like not to further escalation of treatment, even antibiotic, and not for ventilation. These type of policies should be taken. Do not attempt for resuscitation. This is important. Sometime hospice. I'm taking only couple of minutes time from the organizer to just share my personal experience. My father actually passed away due to stage 4 lung cancer. As per wishes, I have kept him in my country home, arranged everything, all the facilities, trained a quack doctor to give support. And I used to spend whole the weekend, and he was completely happy. And actually, he spent and quite happy last 6 months on his life in my country home with all his previous students, old students. And ultimately, I was there at the last during the last breath, and I have in the CPR. And my mother is also suffering from advanced CA, ovary, and after surgery and chemo, now again she opted for to live in country home, and she is having some chemo-induced neuropathy and fatigue all this issue. But she is trying to come out of this situation and trying to leave the materialistic world slowly, slowly. So just to share these two things by personal and family experience, just to realize that thing, rehabilitation of cancer patient is just not like management of pain or management of particular issue. It's a journey with the patient throughout their lifetime, particularly for the advanced cancer patient. It is very much needed to be with the patient to go through the journey throughout the final days. Thank you so much for your patience here.